I think it's a great question because we now have two very well-conducted trials comparing new oral anticoagulants with warfarin. We have the RELY trial comparing dabigatran with warfarin. We have today the ROCKET-AF trial, which compares rivaroxaban with warfarin. So we can look at each of these trials individually and see what do they show, and then we can think about how do we look at them together? How do we kind of integrate the data from both trials? So let's start with the ROCKET trial because it's the most contemporary, just hot off the press today. So what did that trial show? I think it showed very clearly that rivaroxaban is non-inferior to warfarin for stroke prevention in this very high-risk patient population. So these are the sort of the sickest atrial fibrillation patients that we see. 54% of them had a previous stroke or TIA. So we're looking at mainly at secondary prevention. A lot of hypertension in this group. Hypertension, as you know, is a risk factor for recurrent stroke, probably the biggest risk factor along with a previous stroke or TIA. So we've got a very high-risk population. A lot of heart failure. The heart failure is not just an issue for stroke, but it's also an issue for managing warfarin, because if patients have a congested liver, it's much more difficult to get the INR just where we want it in that 2 to 3 range. So this is a very high-risk patient population. They're older, around 74 years old. Their CHAD score 3.4. They're very high risk for stroke. Lots of secondary prevention. A very, very high-risk population. So we have an agent that is non-inferior to warfarin for stroke prevention. That's great. As far as the intention to treat versus on-treatment analysis, I think we really have to look at intention to treat. So on intention to treat, clearly non-inferior, and it doesn't matter whether you look at the 1.46 non-inferiority margin, the 1.38 non-inferiority margin. It's clearly non-inferior, so there's no question about that. Then what about the safety? Well, here we have a population that's not only at risk for stroke, but they're also at high risk for bleeding because hypertension, previous stroke, older individuals, high CHAD score, all of those are risk factors for bleeding. So what did we see? Overall, the risk of major bleeding, similar with the two treatments. The serious bleeding, the intracranial hemorrhage, significantly lower with rivaroxaban. The critical organ bleeding, significantly lower with rivaroxaban. We saw a little bit more in drop in hemoglobin, a little bit more in transfusion, but it looks like the serious bleeding is lower with rivaroxaban. So we have a drug that's non-inferior to warfarin for efficacy in the highest risk population, and it's got some safety advantages over warfarin in this population that's at high risk for bleeding. So we've got something that's pretty exciting. And if this were the only thing we had, we would be ecstatic because all of a sudden we have once daily therapy given fixed dose, no monitoring, that's at least as good as warfarin and is safer. So fantastic. But we have to look at these data in the context of what did RELY show. So the RELY trial compared 2 different doses of dabigatran with warfarin in a lower risk patient population. Younger, mean age of 71 instead of 74, CHAD score of 2.1 instead of 3.4, only 20% previous stroke or TIA, not as much heart failure, maybe 30% versus 60%, not as much hypertension, so a lower risk patient population. What did it show? The lower dose dabigatran regimen, the 110 twice a day regimen, was clearly non-inferior to warfarin, but showed superior safety. Less major bleeding, less intracranial bleeding, less fatal bleeding, so clearly superior on the safety side and non-inferior on the efficacy side. The higher dose, the 150 milligram twice a day, was superior for efficacy and similar for major bleeding. Again, less intracranial hemorrhage, less life-threatening hemorrhage. So we have there, with the higher dose regimen, something that is superior for efficacy and for the critical bleeding is significantly better than warfarin. So how do we put that then in context with what we have with Rocket AF? But we have to remember that in RELY, again, only 20% of the patients had a previous stroke or TIA. We had only about a third of the patients who were in this high-risk CHADS 3 or above category. So we don't have as robust an estimate of how dabigatran performs in these very, very high-risk patients. But if we look at the results with the 150 milligram dose by CHADS category, there's no evidence that there's any difference between those who are low risk, intermediate risk, or high risk. It's solid right across the board. There's no evidence that there's heterogeneity among those groups. Intracranial hemorrhage is lower with all CHAD scores. Similar results whether you had a previous stroke or didn't have a previous stroke. So it's hard to say there. We've got some challenges. If Rocket were all we had, this would be great. We've reached the pinnacle. I think the issue is that with the RELY trial, we've kind of set our expectations higher because we saw for the first time that you can beat well-managed warfarin. And so the expectation is we want more than non-inferiority. I think it's important to point out that all of these trials, those that we've heard about and two others that are ongoing, Aristotle and Engage, they're all non-inferiority trials. We're all looking for non-inferiority, and if we get that, then we can test for superiority. So we've got a bit of a dilemma here, but we've got fascinating data, and there's no doubt that rivaroxaban is a very effective drug for stroke prevention and atrial fibrillation, and it's a drug that could be used in the highest risk patients. In summary, I think we've got very exciting results. We've seen two trials, both comparing new agents with warfarin, and we can see some differences in the populations that were studied, but some similarities in the results. And what are those similarities? We've seen that with unmonitored fixed dose therapy, we now can get stroke reduction that's at least as good as we see with warfarin. And warfarin management in these trials is way better than warfarin management in the community. So when we look at these trial data, we're seeing warfarin at its best and not the way warfarin is behaving in the community. What are some of the other things that they have in common? Well, we've seen that with these new targeted therapies, we're getting better safety for our patients, less intracranial bleeding, less critical site bleeding. And remember, it's that intracranial bleeding that is either fatal or it creates so much morbidity that you wish it were fatal. So this is the most serious type of bleeding. This is what we all fear when we give anticoagulant therapy, and we see that we can reduce that risk with either a drug that targets thrombin, dabigatran, or a drug that targets 10A, rivaroxaban. So that's exciting. We can better walk that delicate balance between efficacy and safety with these new agents, and they're so much easier to give. That's a huge advance for our patients, and the idea that we now have choices will make it much, much better as we manage patients with atrial fibrillation.